Good morning, everyone. We'll go ahead and get the festivities started. So we're just absolutely delighted to welcome Dr. Folasade May back to Yale. So Dr. May graduated cum laude from Yale University with a degree in molecular, cellular, and developmental biology. She attended the University of Cambridge to study epidemiology and international health, earning a master's of philosophy in epidemiology, and attended Harvard Medical School. During her gastroenterology fellowship at UCLA, she earned a PhD in health policy and management from the UCLA Fielding School of Public Health. Her doctoral dissertation addressed Black-white disparities in colorectal cancer incidence, screening, and outcomes. Dr. May's lab engages in health services research and quality improvement related to population health, preventive medicine, and health disparities. The lab's research spans several areas from the epidemiology of disease and disease risk factors to implementation science to improve disease outcomes. As director of the Melvin and Brendan Simon Gastroenterology Quality Improvement Program, Dr. May also oversees a portfolio of quality improvement projects at UCLA Health to improve the quality of care for UCLA Health patients with gastrointestinal and liver conditions. Dr. May is passionate about improving awareness about preventive health and health equity and is involved in advocacy at the state and national level to develop and encourage policy to improve healthcare delivery. So we're going to do a quick photo with a presentation of the plaque beforehand. So again, we are so delighted to have Dr. May and welcome back to Yale.
Thank you so much for that introduction.
Yeah, absolutely. So here we go. One of you. I'm happy to be in the photo.
Thank you so much.
I'll have to get the picture.
Thank you so much.
And we will mail this to you.
So beautiful.
Yes.
Thank you, everybody.
You don't need my eyes.
Those are your glasses there. Fantastic. Okay, well, thank you very much for that wonderful introduction and for the invitation to be here. It's an absolute honor to be here at the Yale Cancer Center today and to speak with all of you. And I'm actually really excited to see so many people live in the audience on a Friday morning. So thank you for weathering the weather and for coming to meet in person. And thank you as well for those of you online who I know are listening in. I am going to try and keep my eye on the chat and the Q&A. So if you do have questions, please add those there. Also, if you're here live in the audience, please interrupt me if anything's unclear, if you have any questions. Today, I'm going to be talking about inequities in colorectal cancer screening and outcomes, which is what a large majority of the work is in my lab. I'll start by here just providing my disclosures. And since we are at Yale, I have to start with a few stories. So I was very honored to receive this invitation to come here today. Thank you. But I also was excited to share about the work that we're doing, and it also gave me some opportunity to reflect, because it's actually been 20 years since I've been on this campus. I graduated from Yale undergrad in 2002. I came back 2 years after that for a conference, and then I haven't been back since. This is actually a picture of my parents who trusted me leaving Los Angeles to come to the East Coast for the very first time. I'd never even visited, to become an undergrad here at Yale. That young man is my brother, who's now much taller than me. So this is them dropping me off at Old Campus in August of 1998. I had an extraordinary 4 years here. I say that they were the years that helped me become who I am. That's me studying rigorously in my dorm room here in Farnham Hall. I played on the JV volleyball team here, wasn't tall enough to play varsity. And then there's some pictures as well from my last week at Yale when I went through graduation. So I really think of Yale as kind of the beginning, I think, as many of us do, I think of college as the beginning of your adulthood, your opportunity to think independently. This is where I became impassioned about global health, social justice, medicine, and research. And for me, this is kind of a full circle moment to be back here. I got in a little early yesterday and got to walk around campus. So I also want to thank you for the opportunity to do that. So with that context, where am I now? So as mentioned, I work at UCLA Health. After my time at Yale, I spent some time in the UK, and then I was in Boston for a long time, maybe a little too long. And then it got very cold, and we had our first child, and we said, you know what, California is looking pretty good right now. So we went back to California. My husband's from Northern California. I'm from Southern California. And I did my GI fellowship at UCLA. UCLA has this amazing opportunity. I know there's a similar program here. It's called the STAR program that gives fellows, so these are people who finished their internal medicine training, I had left MGH after my internal medicine training, thinking I wanted to do research, but I hadn't had a chance to do an MD PhD program and kind of regretted that I never did that PhD. So when I got to UCLA, we had this STAR program where you can actually do a PhD at the same time as your clinical fellowship. So as I did my GI fellowship, I received a PhD in health policy and management, which is really a health services degree. And really, from that point, did never look back from doing research. I was able to start the May lab in 2015, and I became the director of quality for our health systems in GI in 2016. So right now, this is kind of how I split my time. I do spend a lot of time running a research program. I do include the quality improvement in the research bucket because we do publish a lot of that work. And then I do about 20% patient care. I am involved in running the STAR program now, so that's my way of giving back. And I also have some small involvement in global health at our global health program at the David Geffen School of Medicine. In the lab, it's largely health services research. There is a heavy lean towards cancer. We're going to talk today about one of these cancers and health equity. But we also do a lot of clinical epi. As mentioned, I did an epi degree before I even went to medical school. We run clinical trials, including some of the big national GI clinical trials that are going on right now, and have a lot of a foothold in population health and how you roll out interventions across the health system, which ties into the QI work. Today, however, we're going to talk about one specific disease that I would say is the majority of my research, and that's in colorectal cancer. I'm going to start by talking about national trends in this disease, focusing on two areas that are of high interest to me: disparities in early onset disease. And then we'll also talk about colorectal cancer screening disparities, including the challenges that we have in barriers to screening and potential solutions. And then I'll end with a couple things that I think are important as we move forward in this area. So I'm going to assume that everyone in here is not going to be too shocked by this slide, but many people are surprised to hear about the large burden of colorectal cancer in the United States and globally. It is the third most common cause of cancer for men and women in the United States, and second most common cause of cancer-related deaths in the United States. And even though we have very effective screening modalities and a national call for everyone at some point in their life to be screened, 1 in 3 adults in the US do not get screened for colorectal cancer, which is a problem that many of us have been trying to tackle since the 1990s. Some of us do consider colorectal cancer a success story. Since the mid-1980s, we have had a decline in incidence and mortality from this disease, and you can see that on the figure that's up here on this slide. For men, women, and overall, we've had a drop in overall numbers looking at all age groups in this disease. And we attribute that to the introduction of screening, to the uptake of screening and those who've participated, but also partially into some improvements that we've had in treatment and reduction in risk factors. We do think that some of the reduction in smoking has contributed to some of the reduction in the number of polyps that we see and polyp progression to colorectal cancers. But I do want to mention that it's a success story with a caveat, a couple caveats. The first being that there are massive disparities in colorectal cancer. The group that has the highest incidence of colorectal cancer is our American Indian Alaska Native population. Those two groups are often combined in national databases, including SEER, because they're small, but I want to highlight that they are very distinct populations. And actually, if you separate it, it's the Alaska Native group that's largely driving this epi phenomena that we see. And then after that, we have Black individuals in the United States having the second highest rates of colorectal cancer, then white Americans, then our Latino population, followed by our Asian and Pacific Islander population. So even though in the Asian Pacific Islander population, it's a relatively lower incidence and mortality than in white, Black, or Native Americans, I do want to say and highlight that for our Asian individuals, it's still the number 2 cause of cancer-related mortality. So in all of these groups, there's significant burden. We also know that we have similar trends for mortality of colorectal cancer. Now, the bars here are going to be lower because we have fewer deaths than we have cases. But again, we're going to see that the largest number of deaths are going to be in our Native communities, followed by Black individuals, white individuals, Latinos, and then Asians. We also care a lot about stage, because for colorectal cancer, we know that if we can diagnose this disease at stage 1, the survival is over 90%. Survival at stage 4 is 13% or lower. So we do pay a lot of attention to stage at diagnosis. And when you look at distant stage at the time of diagnosis, we have the worst case for Black individuals, where 25% of cases are being diagnosed at a late stage. 5-year survival, similar disparities and trends where you have worse outcomes for Black individuals and Alaska Native American Indian populations than you do in the other subgroups. The other caveat to the success story is the recent trend that we've seen for the age of onset of disease, which we call early age onset disease. These are individuals who are diagnosed with colorectal cancer under the age of 50. Now, I'll tell you, it wasn't too long ago that I was an internal medicine resident, and I was taught that colorectal cancer is the disease that you look for people in their 60s, 70s, or 80s. I no longer teach that to my residents and fellows. This is the disease that we need to be aware of in people in their 30s, 40s, and 50s. And that's because of these different trends that we've seen. So if you look at individuals age 0 to 49, which is the first graph, we have increasing rates or incidence over time. We have some plateauing as well in individuals that are 50 to 64. This was a slope that 10 years ago was clearly downward, and now we are seeing that even in middle-aged adults in their 50s and early 60s, that we don't see the huge impact that we did of screening and treatment before. And the group that we're still seeing a big benefit is individuals over age 65, which again, we attribute to higher uptake of screening and greater penetrance over time of screening programs. Mortality, we're seeing the same thing. Unfortunately, we're not seeing this downward slope in mortality, particularly with the under 50 group, we're seeing an upward swing in mortality. And even when you look at individuals over 65, there's some concern for plateauing. So this big success story that we've been touting is now at risk, not only because of the disparities that we see, but because of early onset disease. This is actually a publication that I co-wrote with some incredible colleagues led by Samir Gupta at UCSD, where we did an overview of early onset colorectal cancer. And we were able to show using SEER data that when you look from 1992 to 2019, there's actually a notable shift in the proportion of individuals who are diagnosed with disease. I'll highlight first the group that is age 40 to 49. That's this darker red, 5% of cases in 1992. And then in 2019, where we have the most complete SEER data, that population increased to 9%. Again, looking at individuals 50 to 59, that population was about 12% in 1992, and now is 21%. So these are profound changes in the epidemiology of disease. I'm also including here a slide on the demographic profile by race and ethnicity using the same data. As you can see, in 1992, 76% of cases were non-Hispanic white individuals. That has dropped to 58% of cases in 2019, probably even lower now if we actually had 2023 data. And that is attributed to, as you can see here, an increase in the number of cases in Latino Hispanic individuals and non-Hispanic American Indian Alaska Native individuals, and also in non-Hispanic Black individuals. So in that context, I want to talk a little bit about what's going on in the screening world and some of the work that we're doing to help close some of these gaps. Just to make sure that we are all starting on the same page, colorectal cancer is very unique in that we have a precursor lesion called a polyp. So when I am doing a procedure, let's see if I can use my mouse here. This is what this is what a normal colon looks like when I'm in the colon with a scope, obviously. Can you see my pointer? No, you can't see my pointer. Let's see. Does this work? I should have checked this technology before. I tried using the mouse. It's not showing, but I'll describe. So the normal colon picture, that is a nice looking colon. As Dr. Lane knows, that's what we want to see when we're doing a colonoscopy. It's sparkly, it's pink, there's no polyps. In about 50% of people, however, we're going to see a polyp. And in about 25% of people, those polyps are pre-malignant. Now, when we're looking at a polyp, we often cannot tell which one of those has the opportunity or the likelihood to progress into cancer. So we typically take out all the polyps that we see during a screening colonoscopy. Unfortunately, though, if these polyps are left to themselves after years and years and years, they can develop into colorectal cancer. And this is the progression that we're trying to stop when we do screening for colorectal cancer. So we have two opportunities with colorectal cancer, which is very different from many other cancers. We can find the polyps and take them out before they transition to cancer. What that means is that's less people hearing the words, you have cancer, right? Because they never had cancer. But we also have the opportunity of finding a cancer early enough that you have that 90% cure rate, that the words are more, you have stage 1 cancer, we likely can cure you, hopefully. So again, there's the prevention and an early detection benefit of screening. We know that screening is effective. We actually have RCT data that supports mostly guaiac FOBT and flexible sigmoidoscopy, and that's been extrapolated to assume that there's RCT evidence to support studies like FIT and colonoscopy, which are similar methodologies. Right now, the most common screening test in the United States is colonoscopy. In some health systems, it's up to 85% of screening, but we're about 70% national. And then of the stool-based screening modalities, FIT, or fecal immunochemical testing, is the most common. Those are supported mostly by large observational studies. And also this really, I think, amazing figure that was produced by Ann Zauber, an epidemiologist, and her group that showed that over time, the red line is the incidence of colorectal cancer. The blue line is the incidence of colonoscopy uptake. And as you can see in the United States, as we've been using more colonoscopy, that incidence line is coming down. So another kind of observational piece of data that shows this early success story. Now, as I mentioned before, though, we don't see this in our young adults because we don't screen our young adults. And these are data that were released in JAMA Network Open, where they did a projection or a modeling study that showed that because of this 51% increase in young onset colorectal cancer since 1994, colorectal cancer is actually predicted to be the leading cause of cancer-related deaths for individuals aged 20 to 49 by 2030. And actually, the report that was released by the American Cancer Society just last month suggests that we're actually there, where we're seeing, and particularly in men, that colorectal cancer aged 20 to 49 is the #1 cause of cancer-related deaths. And women, it's #2. By 2030, we'll probably be there for both groups. This change in epidemiology is largely what prompted the change in the United States Preventive Service Task Force recommendations in 2021. These are looked at every few years, and every year previously, the recommendation had been grade A to start screening at age 50. We now have a grade B recommendation that people 45 to 49 should also be screened for colorectal cancer. This matters because everything that's grade A or B by USPSTF is mandated insurance coverage. And this is why, even though the American Cancer Society said this back in 2018, it's just now that we're starting to screen all of our 45 to 49-year-olds. I'll highlight that this is for average risk individuals. If there's a family history, a polyposis syndrome, or hereditary syndrome, we're actually going to screen much earlier. These are the USPSTF recommended screening modalities. As I alluded to before, we've got stool-based strategies, and then we've got what we call direct visualization techniques. Among the stool-based strategy, there's high sensitivity FOBT, which is mostly out of favor. We have FIT, which is the #1 stool-based strategy, and then stool DNA, otherwise known as Cologuard. You've probably seen the commercial with the cartoon in the little white box, which is growing in use. And actually, we just saw last month in the New England Journal the release of the data for the Cologuard version 2.0, which is a newer version of their test that performs slightly better. The direct visualization techniques are also listed here. These are all acceptable ways to screen for colorectal cancer. And I think what's most shocking is that despite the fact that this is a rising burden of disease, a concerning disease that is highly impactful, despite the fact that we have evidence that screening works and the fact that everyone should be screened, we still have a problem with only about 67% of people being screened, even when we have all of these options for our patients. So we still are trying to find ways to have more people participate in screening. When you participate in one of the screening tests that is not a colonoscopy, we don't have the opportunity to go in and grab those polyps or biopsy those early cancers. So we do call those two-step screening processes. So whether you're talking about FIT, Cologuard, FOBT, or CT colonography, If a polyp is found or an abnormality is found during one of these tests, it's actually required that you have the second step, which is colonoscopy, to complete the screening process. Now, this seems obvious, right? But I work in settings where only 18% of patients have that throughput from abnormal FIT or abnormal stool-based testing to the completion colonoscopy. Participation in screening varies broadly across patient demographics. These are data from the National Health Interview Survey. So the caveat here is that these are patient reported data. And if anything, we've found that when you look at EHR data versus patient reported data, the patient reported data actually is maybe a little higher. Patients like to report that they've done things that maybe they haven't. So we're going to take this with a caveat that 59% at the top, we're probably even lower than that in these patients. And there's also a lot of misremembering. I mean, I can't tell you how many times I've asked a patient, when did you have your colonoscopy? And they said, oh, it was last year. And then we look on the chart and it was 6 years ago. Nowhere close, right? And it happens with the stool-based test as well. So overall, we're not doing very well at the top of the chart at 59%. You'll see the differences by age, of course, just because we've just started screening our 45 to 49-year-olds. We're going to have the lowest uptake in that group. But we also haven't been done very well at screening our 50 to 54-year-olds. And prior to the release of the new guidance, a lot of us were focusing on those 50-year-old patients because those people were underscreened as well. Males and females do pretty well, but we have seen, as I mentioned, big differences by race, ethnicity. I will highlight that in the last 10 years, the Black-white screening gap has narrowed. I don't believe these data completely because when you look at EHR data, there's still more than a 1% difference, but it does signal that we've done a good job of closing that gap. But look at the other non-white racial ethnic groups. Again, when we're looking at our Native populations, Asian and Hispanic individuals, we have a lot of work to do. So this is where a lot of our work focuses on in the underserved, not just our Black community, but our other groups that have low rates as well. I think I also here put a lie where you're born matters. So our immigrant populations have very low screening rates. And then also how your insurance type is going to be a large predictor for screening. So when I talk about inequities and when I talk about underserved, yes, for me, it did start with Black, white, and that's what my dissertation was on for my PhD, but it really has expanded to include Latinos, which is a group that we're seeing the highest rise in early onset. It also includes individuals who are Native American. I'll talk about one of the projects that I have in the tribal nations. And it also includes people who are foreign-born and also who have insurance types that are barriers to them getting screened. The why. This is complicated and I could spend an hour talking about the why, but I've tried to just distill it into a quick slide here on social determinants of health. There are conditions about your life that make it more or less likely for you to participate in your healthcare. You can boil it down to competing demands. I tend to find that a lot of our underserved populations have so many health and non-health competing demands that getting a preventive screening test for a cancer or disease they don't have is off the table. But the more specific reasons for screening have been populated through a myriad of studies. This I thought was really interesting. This is Kaiser Family Foundation data, which I love all the data that they release online. They looked at the number of adverse social determinants of health by race and ethnicity. And they found that if the first bar, if you're a Black individual, you have 16 worse on average social determinants of health than a white individual. And you can see for Latinos, it's similar, but even Asian, our Native populations, and our Native Hawaiian populations as well. So this was, I think, a nice way to quantify these competing demands that happen in life and to kind of at baseline try to understand why it is that when you have 4 children at home, an elderly parent to take care of, 4 jobs, trying to put food on the table, don't even have a primary care provider, the idea of getting screened for colorectal cancer is not even on the list of priorities for you that day or year or month. We've done a lot of work in this area. I'm going to populate this slide. And this also combines work from colleagues in this area where we've tried to look at barriers to screening on a multi-level. I like to look at it as patient, provider, health system, and policy. What struck me most about this work when I started doing it was that everyone wanted to talk about the patient problems, right? The patient being the problem. The patient won't get screened because the patient has this and that and these barriers. But let's also highlight that there are provider factors. So that second box here, there are data that show that when you survey primary care providers, they don't know that there are disparities in colorectal cancer, or they don't get the screening guidance right. They don't know that we've lowered the screening age. We know that your practice setting matters. The number one predictor, in fact, for whether a person is to get screened for colorectal cancer is whether or not their primary care doctor talks to them about it directly. This was one of the first papers that I published with Brennan Spiegel. And when you look at ethnic and racial minorities, that odds ratio is even higher. So a trusted provider telling a patient to get screened is one of the most important predictors, and that's not happening more in those groups. Again, I could spend an hour just on this slide because we know that there's so many barriers. And this is why a lot of the work that we do in this area is about multi-level interventions, where we're trying to pick at many of these barriers in one go with a multi-component intervention. A couple of things I do want to highlight. So policy, because we talk a lot about patient provider system, but I also throw policy in there because I think for a long time there were policy barriers to getting screened. So the ACA, which I am a fan of, actually eliminated issues like copay and mandated coverage for preventive services. That had a huge effect on disparities, not just for colorectal cancer, but other cancers as well. And then we've done some work on the state and national level. We had a law that we got passed 2 years ago about removing barriers to colorectal cancer screening, which removed copay. Believe it or not, if you had a colonoscopy for screening and I took out a polyp, you would get a charge. It's like, that's the purpose of the test. So we finally convinced Congress that that didn't make any sense, and they removed those copays. This is work that's been championed for years, but that law went through, I think, 2.5 years ago. So there are also policy things that have to be addressed for us to close these gaps. I'll talk about those strategies next and how we address these barriers. And this really pulls us into the field of implementation science, which is kind of what we consider where health services research is going to. So in health services research, we're trying to understand how to get the best care, the best quality of care to all people equitably and through health systems or other sources of healthcare delivery. And a lot of that leads up to effective implementation science. In implementation science, especially related to disparities, our first goal is to understand the extent of the disparities, which we've talked about, mechanisms and barriers, why we have the disparity, and particularly for screening. We just looked at that slide. And then we want to come up with evidence-based solutions to those disparities. And then we want to disseminate and scale them so that everyone has access and everyone has improvement in those outcomes. So that's what leads us towards these interventions that are multi-level at the individual, provider, health system, and policy level. And more recently, we've had interventions that are also cued into community. And that's another level of the work that we do. Now, because I came along at a fortunate time where the giants had been working in this field for a long time, we learned a lot. And now we're at a place where we actually know pretty much what works. It's just trying to tailor it for the appropriate population and scale it. And we know, for example, that when we look at effective interventions, did it light up? Yes. There are certain goals that you want in how you design your intervention. You want it to target multiple levels. As I mentioned, you want to address barriers at all those levels, which leads to a multi-component intervention. You want them to be culturally tailored, particularly interventions that involve patient education, where all of the individuals on the pamphlet are appear white or appear male, are not going to appeal to people who come from brown or Black populations or underserved populations, for example. So culturally tailoring the language, the examples, the settings, the people, and then also you want to work closely with the stakeholders. I think we come from, unfortunately, a history since probably the beginning of time where we've come into places and decided what's best for the people there. And this is more around coming into a place, acknowledging that you're coming with expertise, but that those people understand the community best. So when we develop interventions, we sit down with our community leaders and we say, what do you see as the problem and how would you fix it? And then we try to adapt our science to those potential solutions. And I think that's what makes the most exciting brainstorming. That has led to a slew of interventions. And we have, as I mentioned, policy interventions that have been very effective. There's been interventions at the healthcare system level. A lot of those have to do with automation. So a lot of the work that I do with my QI hat is about offloading primary care providers by automating screening for them and prompting them to do things and taking steps and the number of touches on the EHR away from them. We also have interventions that are focused mainly on the provider or her provider components. And also, as I mentioned, communities and patients. So when we're building interventions, a lot of times we're looking at lists like these and we're saying, okay, where do we want to pull from each of these levels as we build our multi-level intervention to address the specific barriers in that community? I'm going to adapt that thinking to the work we've done in federally qualified health centers. So just to make sure that everyone understands what these clinical settings are, these are community-based. They provide only primary care, or that's how the government has structured them. They get funding and resources to provide primary and preventive care. They take care of 30 million Americans in the United States. And although they have offerings for screening or cancer diagnostics, they won't typically have a specialist on site. And so those patients often have to leave the FQHC when they need specialty services, which makes it very tricky for those patients who need that level of care. When you look at screening rates for colorectal cancer in federally qualified health centers, which we really only have for the age group 50 to 75 at this time, the screening rates are much lower than national screening rates. So yes, we've had some improvements over time in federally qualified health centers, the blue line's going up, but look how far below the national screening rate we are. And the national screening rate isn't that great. So that's not even our goal. So in these settings, we have underserved individuals, often brown and Black, often uninsured, often low SES, and very often poorly screened, not just for colorectal cancer, but for pretty much any measure. And that's the challenge of the primary care providers in this setting. Going back to that problem that I'm also interested in, which is completion of screening, even when they do get screened, if that screening is abnormal, like they use a lot of stool-based screening in these settings because it's easier for them to give out, sometimes there's no opportunity to get a colonoscopy. So in some of the series we've done, as low as 18% of the patients who have an abnormal fit get a colonoscopy, which as a fellow, when I started looking into this problem, drove me crazy. And I said, this is definitely where I'm going to do my research. And we're going to talk about that today. So I do this work in LA County, which is a very interesting place to do work in underserved. Our county has 10 million people. We are majority minority. So 72% of Los Angelinos identify as being a person of color. And just in our county, we have 49 FQHCs. And someone told me there was a new one, so it might be 50 now. So this is an incredible setting to do this work. It's an incredible playground. We have 1.1 million people in FQHCs just in our county. And then I got to drive 2 hours south to meet up with Samir Gupta, and I've got the San Diego counties at my disposal as well. And we do a lot of partnership with San Diego. Our populations are similar. So at the Center for Health Equity, which is at UCLA in the UCLA Cancer Center, where I am one of the associate directors, we collaborate with federally qualified health centers. We develop advisory committees with them. We have ongoing clinic engagement. I have staff that literally just sit in an FQHC clinic for a week and just observe how care is administered. We perform key informant interviews. We sit in a conference room with the clinic leadership, with a couple of their providers, and we bring in a couple patients and an interpreter often, and we just talk about what's working, what's not working. And this is how we help them develop multi-level interventions, again, focusing on their system workflow, focusing on their provider and staff, and how to maximize efficiency, and also how to educate and best inform their patients. I'm going to lean into one example with one of our main partners. This is the Northeast Valley. I'm going to call them Northeast Valley from here on out, but it's a large FQHC. They actually have 15 sites throughout Los Angeles. It would take me an hour and a half to drive from one site to another. That's how spread out this one FQHC is. And they've got a lot of patients from different backgrounds. It is largely Latino, 84%, and largely uninsured, with about 90% living below the 200% FPL. I haven't, but my center has been working with this FQHC for 13 years. The partnership was started by Dr. Rashan Bastani, who was one of my mentors during my PhD. They've done work in breast, cervical, HPV vaccination for kids in the clinic, and then now with colorectal cancer. So beginning in 2018, which is when I started working with this clinic, I said, well, I'm a gastroenterologist. I'm going to come into the setting, and of course, I'm going to look at colorectal cancer screening. and their screening rate was about 51% then. It actually dropped to 39% during COVID. And 9% of their fits were abnormal, but only 20% were getting that colonoscopy for completion. And they had no protocols. They had no screening program and no abnormal screening follow-up program. So this was an incredible opportunity for me to come in with Dr. Bastani and talk to them about the work that they're doing. And over the last 6 years now, we've done a slew of work. I know this slide's very busy, but I did want to summarize and try to explain the trajectory here, because with colorectal cancer screening, it's a process of care for which you need all the components. You need to screen more people, but then you need to recognize that those people need to be screened at intervals. And so that's what we call repeat screening. And then you also need to recognize that those people who have abnormal screening need a certain line of care as well. So our 3 buckets of work at Northeast Valley have been in those 3 lines. We've done work in the blue box about increasing the screening rate. That work was first funded by TRDRP, which is a tobacco-related disease program that does funding. But they were very interested because obviously tobacco relationship with colorectal cancer risk. And that grant allowed us to do a cluster randomized trial greater than, I think it ended up being 12,000 patients. And this was a multi-level intervention, mostly about their workflow, as how can we help them reestablish their workflow in the clinic. We offloaded the primary care providers. We got the MAs involved in handing out fit kits. We got different levels, non-MD providers in the clinic involved in explaining the kit, following up with patients. And that was very effective in increasing their overall screening rate. Then we had a postdoc who said, okay, that's great. The patient got screened once in 2018. They have to get screened again 9 to 12 months later. How do we make sure that happens? So she did RO3, or she started a RO3, and also had an internal seed grant to help us work on repeat screening. And with nurses' work, we were able to make sure the clinic was doing recall of the patients. Ends up being about every 9 months. So they have a mental alarm that they're going to be due for screening every year. And then, of course, I came along and I said, okay, well, I'm the gastroenterologist again who does the colonoscopy. So I want to make sure all these patients who have abnormal results get a colonoscopy. And that work started with an NCI RO3, where we proposed that we were going to look at the why. Why is it that patients are falling out in this process? And we created this conceptual framework where we showed that there were 9 things that needed to happen for an abnormal fit patient to get a colonoscopy. And we quantified the fallout or the attrition at each step. And we were able to assess that these primary care doctors were doing very good at seeing that there was an abnormal fit in the chart. They're actually doing very good at ordering the referral to GI. About 85 to 90% of referrals were going in. And then everything was a disaster after that. The patients they were either getting to GI and not doing the colonoscopy, or they never got to GI, or they would get to GI, have an appointment, and then the colonoscopy was not scheduled. So we knew that we had to focus not only just on the internal processes at the FQHC, but that there was another level of this multi-level at the GI practice level where we had to work on that connectedness. And we actually, Beth Glenn and I wrote an RO1 where we said, okay, we're going to do a multi-level on a multi-level, which is kind of crazy. The first time the review did not go well. NIH was like, what are you talking about? Because we proposed doing a multi-level intervention in an FQHC at the same time as doing a multi-level intervention in several GI practices that see their patients. But guess what? We got news 2 weeks ago that it got funded. So this is a very exciting multi-level intervention. We're at Northeast Valley. We are finally going to be able to close this gap. We've done a really good job of improving care at the clinic within the FQHC, but now we're going to be working very closely with GI providers in the LA, in the larger LA community, to make sure that those patients are connected to the GI clinics and make sure that those colonoscopies are completed, and make sure that the reports get back to the FQHC, right? Because if it's not documented in the FQHC's EHR, it's as though it never happened. So part of it was a measurement problem too. And we just got the word that this was scored very well, and we're doing all the paperwork, and hopefully we'll get this work started very shortly, and we're very excited about that. So for me, this work that we've done at Northeast Valley has been really incredible, because I think even as a PhD student, I understood community partnership. I understood what it was. I was starting to understand what it was like to effectively go into community settings and listen and learn and then intervene. But now I've had about 5 projects with them where I've been able to not only see that process, but see the trajectory across the screening spectrum, which has been an incredibly rewarding experience. And you can do this in anything, right? You could do this in breast, cervical cancer screening. The FQHC, we asked them, what are your priorities? And they actually recently told us liver disease. And I was like, okay, that's not me, but we'll find someone who's got this expertise, because they have the similar problem with chronic liver disease, as we know, has become increasing burden in the United States, particularly in these populations, and they can't get those patients into liver care or into transplant evaluation. So it is replicating that model once you've figured out how to do it well and effectively. This work also dovetailed, because I started this work in 2016, 17, and it's been going on my entire career. It's lent opportunities into other settings. So one of the things that came up about 4 years ago was this opportunity from Stand Up to Cancer, which is a nonprofit organization that is about cancer awareness and also works with AACR to fund research. They made an announcement a few years ago. I'll never forget, because I was sitting in my office and it said, Stand Up to Cancer, Colorectal Cancer Equity Dream Team. And I said, well, that sounds like me. It sounds like someone wrote a grant for me. But I'm way too junior and there's no way I'm going to get this, $8 million grant. So I just kind of deleted the email. And I think a few weeks later, Andy Chan at MGH reached out and said, we're thinking about applying for this grant. And I said, that's great. And I said, yeah, I'll consult, I'll help. And he said, no, we want you to run it. And I said, no. So what are you talking about, Andy? But again, another incredible opportunity where I started meeting with him and Jennifer Haas. We pulled the team together, and it kind of just made sense for us to go in, and we were very fortunate to get awarded this grant. It's $8 million. It's same work that I just described to you. Did I do that? Okay, I'm going to keep going. It's the same work that I described to you in Northeast Valley, but it's across the nation. So we picked FQHCs in 3 cities, Los Angeles, Boston, and in South Dakota. Now, why South Dakota? Because of the tribal nations. So we had this incredible opportunity to, in a very careful way, engage with 2 FQHCs in tribal nations of South Dakota. And we are doing the same thing. We're helping them improve their clinic infrastructure to improve their screening. We're helping them improve their repeat screening. And the part that is we're doing right now, we're in the last year of the study, is we are improving their follow-up after abnormal FIT and Cologuard testing. Those are the tests that are most commonly used in these settings. So this has been an incredible opportunity to kind of spread the work that we've learned in local FQHCs in Los Angeles to other parts of the country, and to work with incredible investigators like Dr. Haas and Dr. Chan. This work is wrapping up, so we're kind of hoping that Stand Up to Cancer will give us an opportunity to do more of it moving forward. I think I just have 2 more slides and then I'll have time for questions. I just want to leave with 2 things that I think are important to think about as we think about this field moving forward. I do think that we're just at the beginning of implementation science around colorectal cancer equity, and there are groups all over the country that are doing work, even much better work than what I just described to you. And I'm so excited because it's wonderful to come together at conferences and to be collegial with these individuals. And there's a couple of things that we're noticing that make this work even more relevant to everybody. The demographics in the United States are changing. I don't think anyone in this room is surprised by that, but unfortunately, a lot of others are. And where we look at our demographics in 1980 compared to data from 2020, we know that the proportion of individuals who identify as white, non-Latino is smaller. And we've got a larger proportion of Latinos, Black individuals, and Asian Americans. And in certain parts of the country, it's a different proportion increase. This means that addressing disparities, addressing inequities, understanding what gets different groups to get screened or get testing is even more critically important, because we think that this demographic shift will continue. So I try to remind people that even though this is starting as equity or disparities in a small group of investigators, we all need to learn how to do this work if we really want to address this problem on a national level and similar problems. The other thing that's going to rock our world in colorectal cancer is non-invasive screening tests that are on the verge of driving me crazy. So we are going to have an emergence of stool-based testing and blood-based testing that we hope will be helpful towards screening more individuals. but have potential downsides as well. So why are we having so many more tests? It's because we're still stuck at less than 70% of Americans getting screened for colorectal cancer. There is a huge market to make tests to get more people screened. And I agree with that. I think that certain test types are going to appeal to different population groups. The other thing that is critical to note is that there's a big movement towards ease of testing. So that is why we're seeing the emergence of liquid biopsy, MSED, the idea that when I send a patient to get a Chem7 or a CBC every year, I can just check off a box for their colorectal cancer screening and they don't need to manipulate their stool or do a prep and take 2 days off for a colonoscopy, right? So there's amazing potential in these blood-based tests. We saw the Guardant data that was released in New England Journal last month and raised a lot of excitement. I was quoted in the New York Times as saying that a prep for a colonoscopy was a horrible experience and this potentially could get rid of that, which isn't what I said. What I said was that, what I was trying to say was that patients feel that way, but we have to recognize that these tests are different strategy, right? So I started this whole presentation by saying that the amazing power we have in colorectal is that we can prevent and early detect. These blood-based tests are mostly early detecting. And they're not even early detecting stage 1, they're early detecting stage 2. So we just have to recognize that this motto that Brennan Spiegel taught me when I was a fellow, that the best test is a screening test that gets done. I'm not sure I'm going to be saying that anymore, right? Because to me, it's kind of apples to oranges. We have tests that prevent and early detect, and now we have tests that early detect. My biggest fear and why I get to the slide and bite my lip is that I'm excited about the technology and the emergence of people in our field, but I'm nervous about the interpretation of these tests because I've run into far many people, lay people, but also researchers and clinicians who don't even understand that we're shifting fundamentally from prevention to early detection. That potentially changes, again, the number of people that we say you have cancer to, right? Which is what I started this presentation with. So I am excited. These are not yet recommended by USPSTF, but it's on, I think that our whole field is going to change as those become more and more popular. I'm going to close out here. I think I'm going to just put this up here for a couple minutes, but I'm pretty sure I made all these points. I want you to leave understanding how common this disease is, but how preventable it is. I want you to understand that young adults need to be aware of getting screened and also symptoms and not ignore them. I want you to be aware that the screening guidelines changed and now we're screening at 45, and that despite all the work in this area, we still have profound disparities. What we're doing some work in those areas, but a lot more has to be done. And it really has to do with very sensitive, culturally tailored and targeted interventions. I'm going to end there and I'll just put my thank you slide up. Oh my goodness. And I'm putting this up because that QR code is to my lab if you want to learn more. And then also I obviously want to thank my partners and our funders. So thank you very much.
Thank you so much, and what a fantastic talk. Happy to take questions now.
There's something in the chat too. So
That was so fantastic. Thank you.
thank you.
I have a question about the research you're doing from the FQHC to the clinics. And you mentioned 8 factors you have found that are the barriers to getting the second screening. Can you just say, like, what is the primary barrier that you would think from the systems perspective that is causing the challenge?
There's a chance I have a slide, so I'm just gonna, I have all these extra slides just in case, but I don't think that's one of them. So, okay, what it is, it's not that there are 8 barriers, because that's how we used to think of things, as like whole barriers. What we did is there are 8 steps.
Okay.
So what we did is we went into the clinic and we said, when a patient has an abnormal fit, what's the first thing that has to happen? And the first thing that has to happen is that the doctor has to see the results, right? And believe it or not, there are cases where it's just sitting in the EHR and no one ever noticed it, right? So that's step 1. And then the second step is the provider has to contact the patient and communicate the results. The third step is the provider and the patient have to come to a patient-provider decision that a colonoscopy should be pursued. And by the multi-society task force, full disclosure, I'm part of that task force, but our guideline says that 80% of patients at least who have an abnormal fit should be appropriate for colonoscopy. So the answer to that third step should be yes. Then the next step is the provider needs to place a referral. Then the next step after that is that the referral has to be processed. And that was a step we didn't really acknowledge before because we just thought it just happens. But we realized that a lot of these referrals, they would call the insurer and the insurer would say no, and then no one else would follow up. And so things were getting stuck there. And then this is what was really interesting. In LA, the GI consultants were requiring the patients to have an in-office visit and then a second visit for the colonoscopy. I talked to my colleagues in Boston and New York. Everyone was just taking those patients and putting them into open access and scoping them. But when we did our qualitative interviews, which a part of the NIH grant I didn't go to, the first aim was qualitative interviews, all of the private practitioners in LA were saying it's a disaster when we do that. These patients are coming from a setting where they haven't had procedures, they don't understand the prep, we have language barriers, they have comorbidities, they're showing up with in AFib, we can't do the procedure, it's getting canceled day of. So in LA, particularly with this underserved population, it became very clear to me that I wasn't going to be able to get rid of that step because all of my colleagues were saying, oh, if you get rid of that step, you'll get rid of this, you'll fix this problem. But we have not. We've just tried to streamline that step by doing better medical documentation and pre-procedural workup. Yes. So Rachel Osaka, who's a colleague at University of Washington, she has a systematic review that's just about to come out that looked at effective interventions for fit follow-up and underserved. And they found, I think, 13 interventions in all the body of literature. 8 of them were manuscripts, 5 were abstract, conference abstracts, right? So, and every single one but one involved a navigator. So there is really, in these settings in particular, there's something about patient to human interaction and coaching someone through these 8 or 9 steps that's effective and important. Did I answer your question?
Yes.
Okay.
I want to also thank you for an amazing talk and
Thank you.
for really eloquently outlining how complex it is to develop interventions across all of these levels. So thank you for,
Thank you.
for that
Thank you for
outline.
being here.
One of the things that I'm a huge fan of your work, but what I'm really sort of fanning over right now is your relationship with the federally qualified health centers and acknowledging that, you know, a large majority of our at-risk populations are being served in those settings, but yet we're not able to engage them in research regularly. So you outlined a sort of program that sort of has a longitudinal relationship with these centers. And I wonder if you can just help us understand what it really takes to maintain that relationship and engage those groups, because I think that's where we miss the mark a lot.
I think we miss the mark a lot. And I'm not going to sit here and say that I do this perfectly. I've had missteps. I would say that in every one but one of the FQHCs that I've worked in, the hardest part was trust building. So a lot of these settings I walked into, they had experience with academic institutions, with investigators. They felt almost raped of their data in some situations. So a lot of that first year or so is like courting them, like just showing up. Like, we're here to, I said, I have coordinators that just sit there and just watch and bring in breakfast and, you know, just listen and learn. We are very pushy. Like, I think as academics, we don't realize, and it probably is very efficient and effective people. You just were like in 5 states in the last 2 days. We are very efficient people and we like things like this. And you go into those settings and you realize if you act like that, it does not work. They just see you as a pushy person who needs to watch your agenda. So a lot of it is the trust building and the relationship building. The second part that I would say, answering your question, is you have to have a really strong like stakeholder in the setting. For us, it tends to at least start with the QI director or someone who has that equivalent role. And sometimes we'll migrate to someone else. We have one of the FQHCs that we're working with for the Stand Up to Cancer grant. It's actually a primary care provider. She just really decided that she loves this work. But you have to have buy-in because that person helps change the culture of the institution and almost gives you cred among all the other providers there. So that's been really important as well. But it's hard. I mean, we've gotten feedback from some of these settings that we were rude on certain days, or I've gotten a call that my project coordinator came in there talking like she knows everything. Like you have to be very careful. I mean, I hate to say it, but even like the way we dress or the jewelry we wear, you have to be very careful when you go into these settings. And you have to be very aware of that. And you have to understand that this takes time. I mean, I started doing this work and Gary Gitnick was the chief of my division. And I told him, I want to do this work. No one does this work, but I'm going to need like 5 years to figure this out. And can you just pay me while I figure this out? And he was like, sure, yeah, we'll figure it out. We'll just pay you. And now it's paying off. But I mean, you have to be at an institution that's going to invest in people and the time. I hope that answers. I could go on forever, but hope that answers. Hi, it's good to see you. Good.
Great talk.
Thank you.
With the stool-based tests,
Mhm.
if you pick out all of it,
You actually can with the FIT. So the sensitivity for FIT for advanced adenoma, which is the polyps we care about, is about 40%. It's for the so the sensitivity is even higher for stage 1 through 4. So we actually think FIT does a pretty good job of both the prevention and early detection. The guaiac, the FOPG does not. It's like 12%. So that's why those have come out of favor. Cologuard is 42%, I think the 1.0. So those two newer tests. And then the Cologuard 2.0, the one that they just released in New England Journal 3 weeks ago, that also has good sensitivity for advanced adenomas. But it's just the liquid, the blood ones that do not. 13%. Yeah.
I mean, I, like you, don't really believe that screening is being done as frequently in Black Americans as white Americans, but that's the data you have. But clearly, mortality is higher in Black individuals.
Yeah.
So there's a problem after diagnosis,
Mhm.
and there's no question about that.
Absolutely.
You have thoughts about that?
Yeah. So, that I do have a slide. Do I have a minute? How many minutes do I have a minute? Okay. So I'm glad you brought that up because we only talked about a piece of the problem, right? So, oh gosh, now I'm using my minute to like scroll through slides. But this is the bigger problem, right? Is that you have disparities at every box. So I've decided to focus on this box, but you could focus on any of those boxes. And recently we had a paper that came out in JAMA that showed differences, black-white differences in treatment. So when you look at guideline directed treatment for colon and rectal cancer, Black individuals are less likely to get the NCCN guideline recommended treatment than white Americans. And that's after we controlled for everything. That was national data.
Prescription or adherence?
Adherence. So when you look at their surgery, chemotherapy, radiation, particularly radiation for rectal cancer, the use of guideline appropriate treatment as laid out in the guidelines was lower in Black individuals. So it's the accumulation of disparities at every one of these boxes that's that 40% mortality difference that you're referring to. Yeah. And
All right.
this alone is a talk, right? Because I mean, we just talked about screening today, but there's differences in risk factors and lifestyle and also survivorship as well. You
Well-
look at like things like sexual dysfunction, GU dysfunction, those are all different by race as well.
I'd like to thank
I
Dr.
could
May
keep
again.
talking, so stop.
No, you're great for her time and presentation today. Thank you so much.
Thank you so much. And thank you for the questions. And I'll stand here for a few minutes in case there are more.
Yep.
Thank you so much.
Yep. I'm gonna